Good afternoon, everyone. My name is Blair Adams. I'm a manager with the Disability Services Division of Alberta Human Services. It's my pleasure to welcome you to today's Alberta Brain Injury Initiative webinar. This is the second in a new series of 4 monthly sessions to raise awareness about brain injury, and the support's available for survivors and their caregivers in Alberta. Today's webinar will focus on what happens after our diagnosis. Our first presenter is Dr. Massey. Dr. Massey is a chartered clinical psychologist and an adjunct professor of educational psychology at the University of Alberta. He will discuss the risks survivors face in developing a mental illness after a brain injury diagnosis. He will share practical strategies one can use to manage after a diagnosis. Our second presenter is Natasha Bodei. Ms. Bodei is the Acting Executive Director of the Southern Alberta Brain Injury Society. She will explain the grief and lifestyle changes one experiences after a brain injury. She will also talk about employment challenges and modifications individuals may experience. We're excited to have these two distinguished presenters with us today. Each will speak for about 20 minutes, and then we'll open the session to your questions. Please share your thoughts and questions via the live chat window as you watch their presentations. We will do our best to get to as many of them as possible. Tina Faze is our online moderator. She'll post your web chat questions to our guests. I now hand it off to Dr. Massey.
Thank you for allowing me the time to speak on this very important subject. I've been trying to do that for over 25 years, and hopefully we'll talk a little bit, or at least introduce you to some of the problems that are associated with brain injuries, especially after they've been diagnosed. Okay? And I'm going to read some of this because I'm a little old. The basic issue is the survival from head injury has skyrocketed since the 1970s, and that's because we've had better procedures to neuroimage this stuff, and also we're identifying more details in regards to these injuries. There's a couple of things to keep in mind. We're really talking about two types of injuries. One is an injury that you may have as an adult, and the other is an injury in childhood. They're both pretty bad, and they can both lead to serious problems later on. So we're going to talk a lot more about neuropsychiatric problems because these are the ones that keep coming up, and hopefully we'll get a better understanding of those as we do them. Most of the problem related to this has to do with the location of the injury in the brain and the dynamics. For example, the age of the person, the pre-morbid or the pre-existing characteristics of the person, and how it's sort of manifested. So we'll talk a little bit about that as the time goes on, and then hopefully entertain some questions. Excuse me, I'm just recovering from this flu. The predictors of what would happen after an injury largely depends on how severe the injury is, although it depends on your age as well. So a childhood brain injury, for example, will have more problems associated with it because the person is still yet to grow and develop, whereas an adult, depending on the nature of the injury, may not be as severe because they've already lived a fair length of time. But basically, there's a great variation among people in terms of what they experience following an injury. I should add to that we're mostly talking about closed head injuries, which means there's nothing penetrating into the skull, but the injury occurs within the skull. And that's the most common type of car accident type injury, sports concussion injury. Most injuries follow that pattern. And we're also going to be talking about what happens when you're out of the hospital, because this is the acute phase is different than the post-acute phase, right, after the hospital. So while neuropsychiatric problems are fairly common, a person could be fairly calm or quite agitated after an injury. And sometimes these things don't show up until at least years after the person's out of the hospital. So the difficulties in establishing what type of problem it is largely depends on what symptoms are being seen. Mostly these symptoms are seen by family members and not the person themselves. And that means it adds extra stress to the family. So, for example, I'll just use some statistics here. The problems that a person might experience may continue for years, or new psychiatric problems might develop after the fact, once the person is discharged from the hospital, that is. In one study, which documented changes in personality and emotional functioning in up to 2/3 of adults with severe closed head injuries, that is, and up to 10 to 15 years after their injury. So we're talking about a long period of time. In another study, 20% of 40 subjects developed post-traumatic psychosis, which is more psychiatric difficulties, with the onset of their symptoms about 3 months after to 9 years after their injury. So we're really talking about a long period of time. So these changes to the personality, emotional functioning, they are noticed at times by the patients themselves, but mostly by the family members or people around them. Another little caveat is that if the patients were injured before the age of 21, there are some problems that you notice actually well into adulthood. These could be things like changes in your apathy, aggression, irritability, childishness, acting more immature, and poor relationships with people. So these are the types of things that people can experience, and they all look like something else, right? The pathological behaviors that can show up are often referred to as either delirium or post-traumatic psychiatric problems. There's a whole range of them. And in addition, you can develop things like anxiety, depression, mood disorders, turn to substance use, then it becomes another problem. Other organic or brain-related mental disorders, and they're classified differently because the origin of the problem is organic or brain injury related. So we have a variety of problems that show up. Most of the time, the family or the individual is trying to adjust to a new environment, or the environment that is now new for them, and they can develop a variety of issues. There's one good example that occurs often. This is after car accident injury or whiplash type injury. You've probably heard of it. It's called post-concussion syndrome. And this is kind of a weird one because it has symptoms that are all over the map. And for example, there are problems that are emotional, behavioral. There are problems that can occur due to lack of attention span. There are headaches that often happen, dizziness, some memory loss, changeability in mood, increased sensitivity to sounds. So not being inhibited enough, in other words, the words come right out of your mouth rather than being processed in your brain first. Depression, lost work, fatigue. So all of these symptoms are quite varied, but they can occur in this thing called post-concussion syndrome. And it's very hard to treat because it's hard to figure out what it is. Most of the time it's transient. In other words, it's gone within a year, maybe a year and a half, but sometimes it lingers, and that can be a problem. So you could pretty well pick any type of disorder in this classification system of mental disorders, and there'll be a correlation for brain injury. And that makes it very, very difficult to find any kind of treatment or rehabilitation, because what are you treating and what are you trying to rehabilitate, right? So let me talk just a little bit about treatment, because I want to make sure that we cover that. The post-traumatic neuropsychiatric problems that you can develop require many different disciplines to help treat you. So it can't just be a family doctor or whatever. It has to be a lot of individuals dealing with their different disciplines. The maladaptive behaviors that you may demonstrate, or a person might demonstrate, are so varied that you have to do it that way, right? Sometimes, like for example in my forensic work, I go to the youth jail or the adult jails, and there's a lot of people in there that have had head injuries in the past and seizure disorders and other developmental disabilities, but what they're in there for is their criminal behavior. And that's a very significant finding. It's reproduced everywhere. The other issue is we don't think of it this same way, but child abuse can result in brain injury. And that has long-lasting effects, especially if you have some of the more severe types of child abuse, right? So, for example, using a forensic example, in one study, up to 10% of the children and adolescents that were incarcerated, let's say, had a history of head injury, as opposed to only 3% of children in there that didn't have one. So it's pretty high statistics. When you have a head injury, you often will go into a period of coma, and that's when you're not really actively processing information. And the length of that coma is also important. The longer the coma, the worse the outcome. That's after you wake up. So there's all these other variables to consider. The only way to really differentiate whether you're going to have these problems or not is to have a very thorough neuropsychological examination. And that's what I do in my clinical practice. We apply lots of brain and behavior tests to individuals of all ages, try to figure out where they should be versus where they are, and what the prognosis might be. So these are not just IQ tests, because IQ is irrelevant in this situation. Your IQ stays pretty well the same if you've had a head injury, so it's not a discriminating factor. So the treatment idea here is to figure out what is wrong, what system is faulty, and is there something we can do to perk it up or improve it. In many cases, you just have to adapt to it, or the family has to adapt to it. So what we want to do in the goal of treatment is to, of course, figure out what's wrong and try to figure out how to change the maladaptive behavior to something that's a little bit more positive or socially acceptable, and how it would then generalize to everyday life. That's what we're trying to achieve. So the importance of using the whole family, whoever the caregivers are, in this process is significant, because they're really the ones that can see some change happening in the good or bad direction, and they're the ones you want to recruit. Because remember, at first they're going to be in denial, then they're going to say, oh, well, the person's fine now and let's just get on with it. So they're setting very high expectations for the said patient to improve, and that could be a problem. And remember, families work in a weird way. They're kind of doing a dance together all the time. And if somebody's not dancing the right way, there's a problem with the whole family. And then the finger is pointed and, you know, whatever. So the whole family has to be involved in this process, because the whole system is disrupted. Roles can change. What someone is supposed to do in the family. If a person can't remember to gather up all the garbage to take it out, that's a problem. So someone has to either take over that function or help them do that. And most families are unprepared, or they lack the knowledge necessary to help. And then they have to figure out where to go to get that help, and which is where the brain injury societies and others come into play, because it's part of rehabilitation, right? So families show different styles also of adapting. In other words, some families can take quite a bit of someone dancing the wrong way, and other families are very intolerant to that. So we have to work with the family. Then there's that aspect of anger, not just from the patient, but anger from others around them. Why is this person getting better? What's wrong with this person? Why can't they figure it out, right? And of course, some things are very, very complicated. Certain strokes can leave a person sort of okay, but in some things not okay. Like you wake up and you don't recognize it's your wife beside you, some stranger. That can be a problem, right? So most of this is information gathering and sharing with people, and getting them to the right professionals to figure out what the issue is. And also to understanding the link with brain injury, because that's very, very important to understand. If we don't understand that this is coming from a damaged or impaired brain, we might think that a person is just depressed or, or whatever, and it's really not the case. But really, depression and anxiety are the very common reactions that people experience either from the family or from the patient. But the patient often doesn't know that they're experiencing it. Family members do, right? Then you have the situation of maybe a person was a little bit off to begin with, and then they had a brain injury, and now they're really off. So those are the variables. But we have to get the support from everyone around you, friends, the clergy, counselors, family physicians. Everybody has to kind of do that same thing with you. It tends to work when the services are in place, and mostly it's setting proper expectations for both the patient and the family members, right? That's very, very important. So families, it comes down to families because really it's your support system. They're good, they have good psychological resources, families do, once they are in tune with what's going on, right? And of course they continue to hope, families do. And you have to give them that sense of hope, but in a realistic way. And that's the key here. So in whatever I've found in this whole area, the stability of the family becomes very important when you're trying to deal with a patient, whether it's a child or an adult. And that's where the community resources are used the best, I think. That's all I had.
Thank you, Dr. Massey. If you have any questions for Dr. Massey, please post them in the live chat window and we'll get to them in the Q&A portion of the session in about 20 minutes. I also want to mention that today's webinar is being recorded and the video will be posted on the Alberta Brain Injury Initiative website in the coming days. To find out when the videos are posted and get details about future webinars, please subscribe to our new mailing list at online at humanservices.alberta.ca/brain-injury. Now, I will hand it off to our second speaker, Natasha Bodei.
Thank you, Blair. And thank you for inviting me to Edmonton to present today. So the Southern Alberta Brain Injury is now in its 30th year. We work with adult survivors who acquired their injuries over the age of puberty and who are not eligible for PDD services. We require confirmation of brain injury. We do not provide assessments or rehabilitation. We make referrals to the community-based services and resources and assist with applications and provide informal support. We serve individuals and families in Calgary, Airdrie, Banff, Canmore, High River, Okotoks, and Strathmore. We also serve other communities within these areas. With our intake process, clients can be referred by a doctor, social worker, or other professional. Be referred by family members or friends. And they are also welcome to come in as a self-referral. To be eligible, you must have medical documentation of a brain injury, be over the age of 18, and have acquired the brain injury after puberty. You also have to be willing to engage in and able to benefit from our services. So after referral, there are a few steps before becoming a client. First, you have your application, and then the initial contact from our intake coordinator. This will allow the coordinator to assess whether or not our services will best suit you. Once the assessment has been made, a case manager will be in contact with you to schedule an interview. With service coordination, every client is assigned to a case manager. And SABIS has 5 case managers with caseloads of 30 to 65 clients. Case managers assist clients in accessing services by working with other agencies and resources as well as advocacy when needed. For example, a few things that we do is affordable housing, and supportive housing. We assist people in finding those. Employment services for persons with disabilities. Services to develop life skills, which is with the SCL program, which I'll talk about later. Income support and emergency alert ID cards, which is connected with the Calgary Police. We are developing rewarding roles for survivors as volunteers at SABIS and in the community. Volunteering within the SABIS support groups, peer mentorship programs. It inspires inpatient support program in recovery and stroke. We facilitate a monthly support group on Unit 58 at the Foothills Medical Center. And we also do intakes at the Foothills Medical Center. So I'm going to talk about the grief and lifestyle changes that people go through when faced with a brain injury. While every family or relationship affected by brain injury is unique, there are certain common themes that emerge during the emotional adjustment to brain injury. Everyone involved is faced with a significant loss, role changes, regaining some measure of independence and control, and challenges to interpersonal communication. An individual experiences a trauma, gradually acknowledges its reality, tests oneself, and incorporates changes into one's behavior and thought processes. The disruptions that take place are difficult for everyone involved. Stages are not fixed and are multi-layered. So I'm just going to go through some of the stages that people can go through. The first is shock, second, denial, third, anger, fourth, grief, 5, acknowledgement of reality and letting go, 6, testing oneself, searching for meaning, and internalization. Each individual works through these transitions in their own unique way. There is no specific time with brain injury. Some it takes 3 years, and others it takes a lifetime. Families and support systems will also move through this transition, but at a different rate than a survivor. Becoming a caregiver to someone who has experienced this trauma can be difficult in many ways. Always know that supports are available for those who need it. And hope is the one thing that usually persists through each stage. Brain injury is a life-changing event. Many changes take place in the following area when experienced with a brain injury: family, marriage, a wife or a husband, and even a child. Many have a new person in their home that in itself will create a lot of anxieties. Housing and finances are also some things that change. Sometimes when somebody gets out of the hospital, they aren't able to move back home, and they have to go into a group home or access long-term care. You are grieving the changes that have occurred. It can be difficult for people to accept the now. There are times when asking questions can be difficult when it comes to what happens next. When you are going through these changes, there is no wrong questions. It is important that the survivor as well as the caregiver knows that there are many supports available to them. Some of the employment challenges and modifications that happen after a brain injury, a lot of people who come out of the hospital, they think they can immediately return to their previous positions. Returning to work is a goal for most, but is not always a possibility. If you are in the position to return to work, a good start is becoming a volunteer a few hours a week. A lot of our clients, they will go out in the community and volunteer within the city of Calgary, and this will help to build up their confidence that may have been lost during their recovery. A very small percentage of the population that we work with return to their previous employment. The number is around 1.5%, mostly due to memory as well as physical challenges. Majority of our clients have difficulties remembering what they did the day before. They need constant reminders of what they need to do next. And if you need any assistance with finding employment that best suits you, we can connect you to those services. So some of the supports and services that we offer, depending on what the client needs, depending on what the client's needs are during the intake, we offer a variety of supports to them that are available in the community. A list of supports and services will be provided with all of the supports in the Calgary and area region. Some of the agencies that we refer to, URSA is one of them, Universal Rehabilitation Service Agency, Brain Injury Assist, and CAR, Community Accessible Rehabilitation. For more information on these services, you could see the resource page. SABIS offers weekly support groups. We currently have 5: art, games, living well, stress management, and personal growth. These are offered Tuesdays, Wednesdays, and Thursdays, both morning and afternoons. And our groups are usually about 10 to 20 people, depending on the group. And these groups are really great for individuals who really feel like there's nowhere for them to go. They feel like they don't fit in anywhere, and it's a great opportunity for them to meet with their peers and to talk about some of their concerns. Why these groups are important: they offer clients a safe place to share experiences, expand clients' social networks. Sometimes some of our clients, they don't go anywhere outside of the groups, and the groups are the only things that they have. So it's really great that, you know, if you or your spouse or whoever you know who has a brain injury, it's really good to have them connected in the community. It's also great to get them to develop social skills, confidence, and practice a variety of skills. We also offer companion support groups. We run a 6-week support group called Caregivers, Companions on the Road Less Traveled, twice a year, generally in April and October. This allows participants to share their stories, discuss some of the unique challenges that come with brain injury, and explore options for maintaining their own health and well-being. In Calgary, there is also the Alberta Brain Injury Caregiver Society that offers monthly support groups in Calgary. And for more information, you can call the number on the slide. If you have any questions, please feel free to contact us at any time. Thank you so much.
Thank you, Natasha. If you have any questions for Natasha, please post them in the live chat window and we'll get to them in the next few minutes. I also want to remind you that today's webinar is being recorded and the video will be posted on the Alberta Brain Injury Initiative website in the coming days. To find out about when new videos are posted and get details about future webinars, please subscribe to the new mailing list online at humanservices.alberta.ca/brain injury. So, Dr. Massey, sorry, before we begin with a question, Tina, did you have any questions from the live chat?
Wonderful. I do actually, Blair. Sherry's asking if any of what either of our speakers have talked to apply to someone who's recovering from encephalitis.
The short answer, yes. Absolutely. Because it's an inflammation of the brain and it can cause problems. There's only so much space in the skull. When the brain gets bigger and bigger and bigger, it pushes on the sides of the skull, the bottom of the skull, and the front of the skull. And in the bottom areas and the side areas is where we process a lot of things like emotion, memory, attention span, you name it. So yes, it can, definitely.
And in that way, Natasha, would the services apply to someone who's been diagnosed with that?
Absolutely.
Okay. The second question I have is from Sharon BR. She's saying it's been a year since she's had a concussion, still having memory and concentration issues. What testing can I access to determine how to handle this better, if any?
That one's really easy. Yeah, you would need a neuropsychological assessment to figure out what's going on with that system. And depending on the type of injury and the type of concussion, it could be just temporary symptoms, but certainly that type of assessment will figure it out.
Can you explain what a
Neuropsychological is?
Yes.
Yeah. We apply a whole series of tests that include things like memory tests, reaction time tests, things that are for your age group. We know what you should be able to do for your age and your education. And so there's a whole series of tests. So we're not talking about just testing your IQ or academic skills.
Mm-hmm.
We're talking about very discrete skills. And that can be done easily in one of those examinations. It's fairly lengthy, but it's worth it.
Okay. Colleen has asked a question that I think Natasha's probably directed at you. She's saying she's curious why brain injury has to happen post-puberty for SABIS to provide the services.
Just with the contract that we have, that's what it allows us to work with. SABIS used to work with children, but there's other services available to children.
Could I just provide a response to that? So currently in Alberta, individuals with children who have a disability are able to access supports and services through the Family Support for Children with Disabilities program, and you can access supports until you're 18, and that supports for the child and the family. And so the individual that you were referencing would be eligible for those services. My apologies, but I don't have the number with me right now, but you could contact the Alberta Connects service area center in your area and ask for information about the Family Support for Children with Disabilities program.
Lovely. Thank you, Blair. Dr. Massey, there's a question from an individual says they've had a stroke in the July of 2002 and also another severe brain injury in the summer of 2000. And I believe that injury involved a piece of metal going into their head. I think that these are related to my stroke, but they would like your take. Could that have caused the stroke?
Well, a stroke is usually caused by an incident in the blood vessel, either bursting or being stopped in some way. And the other injury is a penetrating injury, so it's called an open head injury, missile injury. They're two very different things. So it's hard to determine whether one causes the other, but they'll both cause problems. We know that for sure. So whether it's related or not, I don't think is as important a question as how is it affecting you.
Mm-hmm. Okay. Carol has a question. She's asking what kinds of transition services are available to patients being discharged and transitioning from the Halvard Johnson Center in Ponoka to support them and their families psychologically. Natasha, maybe that's for you?
Usually, depending on what their needs are, they would be in contact with us and we would get a referral directly from Ponoka. So whatever, if it's financial or housing, we would be able to direct them to those resources in the community.
What might some of those services be? So if the referral happened, what could they access?
So if they needed income support, we would be able to connect them with AISH.
Okay.
We would help them fill out an application. And if they require housing, there is no housing for brain injury, and that's we get a lot of those questions every week. Do you have housing? So we work really hard to find our clients housing in the area. So
Okay.
those are just some of the things that we would deal with if they want to work on living on their own. Again, we would connect them to SEL support services. So there's a lot of services available. It just depends on the individual.
So they need a referral from a doctor or a...
To come into our services, they could either self-refer or they could have a doctor or social worker.
Okay.
Yeah.
Could I
Lovely,
just
thank
ask
you.
Could I ask a question before we move ahead. Natasha, could you explain what SEL services are?
So supports for community living. So they will work with the person to help them. Let's say if somebody wanted to live on their own, they would go into their home and assist them with cooking, cleaning, just daily needs, taking care of themselves daily, and yeah, I believe they come and work with them on a weekly basis, and currently they have a wait list, so I know that it would take about a month to get into those services, depending on if you were going through IRSA or if you were going through Brain Injury Assist. I know IRSA has a wait list at this moment, but yeah.
I do have more questions.
Mhm.
Dr. Massey, one of our viewers is asking if being premature influences a brain injury recovery time.
Premature birth?
They haven't specified.
What? Well, if it is premature birth, depending on how small you were at birth,
Mm-hmm.
yes, of course, there are some problems associated with that. But how low is low? When I did my study on in pediatrics, birth weights that were around 2 pounds were a problem. And, in most countries, the average birth weight's about 4 pounds for the infant, which is fine. But the lower you get, the worse it is, yes, if it's that.
Yes, actually, the person who asked it confirmed. So yes, so if
Yes,
they're
okay.
premature at birth.
So, yeah. So then we're talking about what's called a developmental brain injury.
Okay.
There are 2 types of injuries. There's traumatic brain injuries and there's developmental ones. So fetal alcohol syndrome, for example, is an example of a developmental brain injury, which is lifelong.
Mm-hmm. Now, Trina asked, actually several people have asked, where does one start for requesting a neuropsychological assessment for an adult?
That's a very good question. There are very limited services available. Most hospitals will have at least one neuropsychologist on staff to conduct evaluations for people that are inpatient.
Mm-hmm.
Then there is some private practitioners who are able to do that, but that's a private fee. There are some government programs that can access neuropsychological services as they relate to either rehabilitation or employment for people with disabilities. So there are some out there. I work with lots of them. And but it is kind of limited because there aren't that many people that have the training to do it.
Mm.
It's very different than standard psychological exams, which you can get anywhere almost. But this is a fairly specialized service. It requires extra training. It requires lots of equipment and lots of experience, because once you have the results, you have to be able to interpret that. So it's one thing to get scores on a test, and it's another thing to actually interpret them.
And just so that I'm clear, the process for getting one would either be a referral from a physician or you pay for the private service.
Yeah, the referral from the physician, if it's going to a hospital, is usually the way to go.
Mm.
But the services for the general public are not covered by healthcare.
Okay.
So it's not a counseling service, and it's not a therapeutic service. It's a diagnostic service.
Right.
And there's the big loophole there. It's just not covered. So unless we can access it through other programs that do exist, it's very difficult to get.
Okay. Issy is asking if it's common for someone recovering from a stroke to have different cognitive abilities from one day to the next, and how could one best help a loved one cope with that?
Different cognitive abilities.
Yeah, from day to day.
You mean different things they can do or not do? I'm assuming that. Yeah, that's very common. Yeah, it depends on where the stroke is and how it's affected them. Some people can have a stroke specific to an area that deals with math, and they can't process math anymore. But usually that stays that way. So, yeah, but I think what the person might be seeing is different things that are able to be done in different environments. which is fairly common. Yeah, it's common. Again, we need to figure out exactly what that is and whether it is something that's significant that will affect the person. For example, can they drive as opposed to ride a bike? So yeah, it is possible to have that. Again, depends on the type of stroke, where it's located, the age of the person when they had the stroke, a whole bunch of variables. And most people will have strokes on the left side of the brain affecting the right side of the body. And just the way the circulation system in the brain is, it's kind of weak that way.
Right.
So they'll have problems with language and memory and that kind of stuff. But occasionally you have a stroke on the other side, which will affect all kinds of other things, but not language. That's the weird one. They speak fine, but they can't find their way back from the bedroom.
So when a caregiver's faced with these kinds of, do you have any coping mechanisms?
Well, yeah, the caregiver needs education
Right.
as to what is going on, which means going back to the source that diagnosed the person and trying to get an estimate of what could I expect, where would the problems lie, and what's something that I have to worry about and not worry about, and how long will this persist? Because remember, the small strokes, called transient ischemic attacks, they can recover quite well. And you may not even notice a change afterwards. But it's some of the bigger strokes where, yeah, the problems tend to linger. So again, it comes down to education of the caregiver, the importance of setting proper goals and for them, what to expect, right?
Right.
I have another question here. Dr. Massey, are there common lifestyle changes survivors can make to decrease the risk of developing a mental illness following their injury?
This is for the person themselves?
Yes.
Oh. Well, yeah, you have to try and make the environment as predictable as possible. Structure, routine, the same thing at the same time. That often helps. So nothing new or unexpected. And to try and reduce one's stress by not putting yourself in a situation where it's something that you used to be able to do but you can't anymore, something like that. And also to keep in touch with your family physician or whoever is treating you to let them know all the little signs that are going on around you. Because most of the time, you know, you would probably say, oh, it's nothing, I'll get over it, sort of thing. It's kind of like a headache. Wait a while, it'll go away. But so again, it comes down to education and getting the right links to whoever it is that may be able to help you. But you have to keep a very predictable, routine, structured home environment. And by that I mean, don't change light bulbs, don't go up on the roof, don't do things that you normally would do, because most accidents happen around the house or around the farm. They don't happen out there on the road. And that's where most people get their brain injuries from, by the way. So having things predictable and safe are very important.
Thank you. Is exercise walking recommended? Does that?
Walking?
Yes.
Well, walking's always good for you, unless you have some major issues with it. Yeah, regular light exercise, depending on what's been prescribed to you, obviously is very good for you, if you can tolerate it.
Right.
And that's the key, right? So you have to check with your family physician or whoever is responsible for your treatment.
Okay. Great.
So you don't just go on the stepper like crazy.
You need to get that approval from your doctor first. Yeah.
That's right.
Thank you. Thank you. Natasha, did you have anything to add on that question?
Actually, we have one of the women that we have in our groups. She walks every day. When she got out of the hospital, she wasn't able to walk. So every day she just built herself up. And yeah, she can walk a half an hour now, no problems. So it's really great to see, you know, for people to understand, you know, you're going through something and it's very traumatic. But to know that there's always hope, and, you know, if you just keep pushing yourself a little bit more every day, you would be amazed at what could happen.
Fantastic. Thank you.
I
Natasha?
do have a couple of questions. So Lee wants to know, once a neuropsychological test has been completed post-stroke, and there's evidence of emotional and behavioral changes that weren't present pre-stroke,
Right.
where does one get help to manage these challenges?
For that, we'd have to look at all the multidisciplinary team members. So you would be seeing a psychiatrist, a mental health worker, etc. Because in the neuropsych exam, there would be specific details and recommendations as to what to do and where to go. That's what is usually done, because that's the way they'll follow through with it. So sometimes it's medication, sometimes it's certain types of counseling, but the therapist would have to know about how to work with people that have had brain injuries. So there's some specialty work involved, but really it's linking them to the right system.
Okay, thank you. Natasha, do you want to add anything to that or no?
Nope.
Okay,
please.
No.
sorry, I thought. So Carol's question is, she asks, how can one address the invisible nature of an acquired brain injury? She says, often outwardly the brain injured person looks and even speaks quote unquote normally, but has a great deal of trouble with memory, goal setting, achieving goals, that kind of thing. Either of you?
You take that one.
I'm not sure what the question is, what she's asking.
Well, the question is, how can she address the invisible elements of an acquired? So yeah, it's kind of day-to-day cognitive stuff.
Does she have the brain injury, or is she the caregiver?
She doesn't say, but the issues are trouble with memory and setting goals, achieving goals, accomplishing tasks.
One of the things that we would recommend is we would send a referral to have supports for community living come in, and they would be able to help with those things. But this is a challenge for you know, if you're the caregiver, it's a challenge every day, because you have this new person in your home, and you have to learn new things again with that person. So the best thing to do is really just reach out and make sure that you're getting in the community and getting the supports that you need.
I can add to that. There are two things going on here. Yes, it is an invisible condition, just on the outside, but it's very visible when you are dealing with systems, right?
Mm.
So the highest method of our thinking is not our intelligence necessarily, but it's what we call executive skills. It's the things that we do every day that we don't really think about, but help us get through the day, right? These executive skills are in different parts of the brain, but they're the ones that are most affected in a brain injury.
Mm.
Okay, it's very hard to figure out which ones they are. But a caregiver will quickly point out what they can't do, right? And the person that's affected won't know that. Okay, so these executive skills, this is your secretary in your head who does all the multitasking and everything you need to do to get through the day, and that secretary is gone. Or away on holidays, right? And you know what happens in an office when
Right.
that happens? It's disarray, right?
Right.
Where do you go, right? So the executive skills are a very important aspect of what we do in a neuropsych exam. So again, if this person had a proper neuropsych exam, we would find out exactly which system is involved and why and where, and then it's a question of adjusting to it by the caregiver,
Mm.
because the person may not be able to change it, right? So if somebody's doing something very annoying, maybe they're not intending to do it, they just don't know what, you know. And then also to figure out, well, what's normal and what isn't normal in a situation like that. Like once you get into your 50s, you have word finding problems. Dysnomia, that's common. You know, get me the thing, you know, that thing,
Right.
very common. Everybody has it. But is it a problem? Well, it's part of aging, right? But if you start developing that in your 20s, after serious drug use, that's a problem,
Right.
okay? So then it becomes an amnestic syndrome. That's bad. So again, we have to figure out what is it. The what is it question is very important. I mean,
Mhm.
if you were to just take medications and not know what your diagnosis is, you're not going to get very far with the medication. Or you'll overdose or not enough or whatever. So you have to know what you're treating. So I think in a situation like this, It is an invisible handicap, that's what people call it, but it's very visible when you're dealing with it. And so the caregiver has to understand what the limitations are and set appropriate goals. And then the person who's suffering with it has to understand as much as they can what's really wrong. They're not going crazy. Maybe their memory system is not so good, but how bad is it, right? And I think once that's dealt with, things tend to calm down. And things become more routine and more structured, and there's little aids to help with doing this and that. We've got our cell phones that beep off when we're supposed to do something, right?
Right.
Even for regular people that have not had a brain injury, like me. So there are ways to compensate for some of these problems, but we need to know what they are.
Thank you for that.
You're welcome.
I have a question from username Slave Lake. The question's about sinus migraines since concussion. I've had such bad sinus migraines that it's very difficult to breathe. Is there anywhere specific to go to get support and information for this? Natasha, maybe?
I would just say to get that information from your doctor.
Okay.
Some of the times we deal a lot with the brain injury program at the Foothills Hospital, and they would be available to answer those questions. We really don't deal with those things in our offices. We would just refer out. I don't know, doctor.
The sinus migraine is after a concussion? Is that what it says?
Actually,
Or is it just a sinus migraine?
no. This person says the doctors they've seen are confusing it with sinusitis, and once I get out of loud environments, sinusitis,
Okay,
yes.
yes.
And once I get out of loud environments and under control, the sinus migraine gets better.
Okay, but is it following an injury to the head?
They haven't said.
Okay, well, yeah, ask your family doctor for a referral to an ear, nose, and throat specialist to start with. And if that doesn't go well, then to a headache specialist.
Okay.
Then from there on, they can do what's necessary.
Another viewer has a question for you, Dr. Massey. As per your comment on executive skills, would that be the difference in testing in a neuropsych versus a psych ed?
Exam? Yes, absolutely. The executive skills are being tested a lot in a neuropsych exam.
Okay.
And so we want to know what happens on everyday functions, how you make decisions, how quickly you can make them. Can you learn from your mistakes in something new, a new environment, right? Yeah, those executive skills are being tapped all the time. Yeah.
And that question about the migraines was yes, following an injury.
Following injury, yeah, then
Yes.
especially be referred to a headache specialist. The migraine syndrome can look like a stroke, and
Oh.
it can have very similar symptoms, including memory loss. So a a headache specialist should be able to differentiate that.
Thank you.
Okay. One more question, Natasha.
Mhm.
What strategies are helpful to assist survivors to return to work if they cannot return to their previous occupation?
It's important that they take the steps to, if they're volunteering, if they volunteer, or there's services that will do an assessment to see what they would be good at doing. Let's say somebody was an engineer and they weren't able to walk, or they had mobility issues. Let's say they had mobility issues, and they maybe could be, helpful in the office. So there's places that will do proper assessments to see what they would be eligible to do. We can't say, they could go out and they can go out in the work world and do a certain thing. We're not equipped to do those types of assessments, but we would definitely help them in that direction. If that's something that they wanted to do, if they wanted to return to work, we would work with them to do that.
Thank you.
By the way, that's also available through a service from the Alberta government, thanks to you folks. the Alberta Human Services does have a division that helps you return to work after an injury or disability or whatever, and they have access to neuropsych exams to help figure out from a vocational point of view, can you work? If so, what kind of work, and how it'll affect you, the services to persons with disabilities. So that's available province-wide. You just have to ask for it.
And actually, on that note, Jen is asking for those living with FASD who had a neuropsych test as a child, should they get a new one as an adult?
Absolutely, yes, because the nature of that developmental brain injury is progressive.
Okay.
In other words, things tend to get worse with time, not better. Because the brain was injured very, very early on, and in other words, the blueprint of the house was wrong when the house was created. So people living in that house starting to notice the electrical's not working, plumbing's not working, and as it gets older, that house gets to have more problems. So yes, absolutely, as an adult, that has to be done.
I have one more question for you. What is a cavernous, I'm going to butcher this,
Intravenous malformation?
No, hemangioma?
Yeah, sure. It's another vascular problem of the brain, and the brain has all the blood vessels in there, and yes, it is a problem of that nature. Now, depending on what it is, how big it is, etc., it's like a tumor, and it's putting pressure at different parts of the brain. So we'd have to figure out where it is and how it's affecting somebody. So there's only so much space inside that brain. So when something's growing in there, it becomes a problem.
That's it.
Any other questions?
Nope.
A big thank you to both of you, Dr. Don Massey and Natasha Bodei, for generously sharing your insights with us. Dr. Massey is a chartered clinical psychologist and an adjunct professor in the Department of Educational Psychology at the University of Alberta. And Natasha Bodei is the acting executive director of the Southern Alberta Brain Injury Society. And thanks to all of you who tuned into this webinar and spent the hour with us. We hope that it's been informative and useful for you. As I mentioned, this webinar is one of a 4-part series taking place every month. Our next webinar is on March 19th at 1 p.m. We'll explore how a brain injury affects relationships and review some of the strategies that builds healthy networks. To get updates and registration information about each of the brain injury webinars, please subscribe to our mailing list by visiting humanservices.alberta.ca/brain-injury. If you're interested in a similar webinar series, the next webinar hosted by Alberta Human Services is about employment for people with disabilities. That session is on March 4th at 1:30 p.m. The topic is to disclose or not to disclose your disability. If you'd like to participate, please register for that webinar at humanservices.alberta.ca/EF. As mentioned, today's webcast was recorded and the video will be posted online along with videos from all previous sessions. The video link will be sent out to all of you who registered in the coming days, and please share this video with anyone you think might be interested. We also will be emailing you an evaluation form shortly. Please take a minute to fill it out. We'd love your feedback. We hope you can join us next month.